Welcome, and thank you for joining this week's webinar in the COVID-19 and Humanitarian Settings Knowledge and Experience Sharing webinar series. This series is produced in partnership between the Johns Hopkins Center for Humanitarian Health, the Health and Humanitarian Crises Center at London School of Hygiene and Tropical Medicine, the Geneva Center for Education and Research in Humanitarian Action, and the READY Initiative. During this webinar, participant microphones have been muted. However, we encourage you to make use of the chat box to communicate with presenters and to ask questions. Access to today's recording will be available after the webinar at readyinitiative.org and on the Johns Hopkins Center for Communication Programs YouTube page. It is now my pleasure to introduce our moderator for today from Columbia University's Mailman School of Public Health Program on Forced Migration and Health, Dr. Les Roberts. Welcome, Dr. Roberts.
Thanks, Ryan. Hi, friends, and welcome. So, in this millennial era, it's a little hard to forget that before Sustainable Development Goals, before Millennial Goals, the United Nations in the 1980s had the goal of giving everyone on the planet water and sanitation. And as part of that, WHO hired academics to do reviews on all kinds of hygiene-related issues. The ability of fly control to reduce diarrhea, the ability of hand washing to reduce diarrhea, proper breastfeeding to improve nutritional anthropometry and reduce diarrhea. And one of those reviews was on the ability of hand washing to reduce respiratory infections. And what is much more forgotten is that that's the only one that was never published in the Bulletin of the World Health Organization because the data was so thin and the studies that were there had almost no effect. Fast forward 20 years, and a pretty good body of evidence that acute respiratory infections, especially in places like Nigeria and Congo, could be reduced by 15, 20% by proper hand washing. A 2012 review found that actually hand washing can reduce diarrhea can reduce respiratory infections in both developed and developing settings, and actually has a modest effect on influenza transmission as well. So along comes COVID-19, compared to all those other respiratory infections for which hygiene is always a secondary issue to reduce transmission. In the case of COVID, we have no proper treatments, we have no vaccine, and therefore hygiene and social distancing are now sort of our main tools for both broadening the curve and for preventing people from getting infected. So today we're going to hear from three people, and all three will speak for approximately 10 minutes. And if you have a question, please write it into the chat box. We will wait till the end of the three presentations and answer questions at that time. Our first person is Sarn White. She is a behavioral change scientist at the London School of Hygiene and Tropical Medicine. She's one of the people that helped set up the COVID-19 Hygiene Hub, and she's going to give us sort of a big picture overview. Sarn, please. Are you there?
Thanks, Liz, for that introduction. Great. So I kind of just wanted to start by outlining a bit of a scope for this webinar. And I'll actually just temporarily put my video off just to make sure I've got sufficient bandwidth. So when we say WASH and COVID-19, it is a little bit different to how we often think about WASH programming during crises and outbreaks. So for coronavirus, the most important community level preventative behaviors are really these three that you see on the screen here. So firstly, hand washing with soap, and this is familiar to almost all of you, I'm sure, since hand washing promotion is the cornerstone of most humanitarian response. In normal settings, in crises, we recognize that diarrheal diseases account for about 40% of all mortality in acute crises, and that hand washing with soap has the potential to almost halve this. But for coronavirus, it's also absolutely key, as Les just mentioned. So we know that the coronavirus can be effectively removed and killed from hands by hand washing with soap. So to encourage hand washing with soap at this time, of course, we need to focus on hand washing infrastructure, products, and we need to design programs which actually change behavior. The second key behavior that kind of comes under this broad heading of WASH is that we need to be promoting cleaning and disinfection of commonly touched surfaces. And this may include encouraging households to clean more often, but also key for the WASH sector is identifying public settings where WASH actors may need to support and facilitate cleaning. And examples of these could include public water and sanitation facilities. The last group of behaviours is physical distancing. And of course, this isn't really a WASH behaviour at all, but we're including it here because hygiene promotion staff are often the frontline staff working with communities. So it's key that they both maintain physical distancing while doing this, but also encourage it in community and crisis affected settings. Physical distancing measures cover a whole range of potential behaviours, including those mentioned here on the slide, but often need to be context adapted, and this is particularly important for challenging crisis affected settings. So I think if you've joined several of the webinars in this series, then the points on this slide might be already self-evident, but I just wanted to reiterate why it's important that we pay particular attention to preventing and controlling COVID-19 in settings that are crisis affected. And this is because crisis affected populations may have greater difficulties in accessing health, social and economic services. They may have limited access to water, sanitation and hygiene infrastructure, and limited engagement with mass or social media. They might also have a higher likelihood of living in crowded environments like camps or informal settings, and they might be more vulnerable to being marginalized and stigmatized. So all of these factors clearly combine to put them at higher risk. It's also important that at a time like this, we take time to learn lessons from previous outbreaks and response programs and utilize this information to inform current work. And I know that Carolyn and Honey, who will speak after me, are going to give you other practical examples of learning from prior humanitarian responses. But here I just wanted to highlight what we know about how behavior changes at a community level during outbreaks. So typically what we see is a sudden increase in information around health and around disease. Indeed, in this pandemic, it's been described by the WHO as an infodemic. And this causes people's risk perception to change. They're suddenly much more concerned and worried about this disease. And this also causes new norms to form at a community level. These three factors combine to cause hygiene behaviours, things like hand washing, to increase without us doing much at all. And we've seen this typically happen in every outbreak of cholera or Ebola or SARS or MERS that we've seen in recent years. So I'm flagging this at this point because at this time, our job really as WASH practitioners is to enable people to do the right thing. And these are behaviors that they already want to practice. So in the coming slides, I'm really just going to go through some key ways that we can enable behavior. So the first thing that we can do to enable behavior is to clearly define the behaviors that we want to do. So the image here on the left is taken from a billboard that I saw in a refugee camp once, and it kind of epitomizes what not to do if you're trying to change behavior. And the reason for this is it's really so general that it's impossible for people to act upon. The other images here relate to the promotion of hand washing with soap. So the middle image here is something you're probably quite familiar with. It shows the 5 critical times that we normally promote for hand washing for the control of diarrheal diseases. But for interrupting the spread of COVID-19, we actually need to think about hand washing at slightly different times, as shown in this poster on the right-hand side from the Global Hand Washing Partnership. So if we want to enable behavior, we really have to start at the most simple level by being clear about which behaviors need to change in order to interrupt transmission. The second thing we need to do is that we need to make sure our behavior change programs are context adapted. And this means that we need to take time to learn from communities and that our programs should actively address barriers for that local context. And so physical distancing is an interesting case study here because, of course, it's a new behavior everywhere in the world. So it's key that programs adapt recommendations to the local context and make general guidelines relevant to the setting where you are working, particularly in settings where physical distancing is likely to be challenging. So on this slide, you can see some nice examples. The first from WaterAid, where they have used common objects in these graphics to help people comprehend and apply physical distancing. The green image at the bottom is from Oxfam's guide for hygiene promoters, and they include this really handy trick to gauge the distance from others by simply reaching out your arm. The two images on the right are examples of culturally adapted ways of encouraging people to stay home and avoid gatherings. So for example, the top image comes from the government of Sudan, who are encouraging people to take their iftar meals at home during Ramadan. And the bottom image is from a really great Pakistani animation where they portray a family making a decision to call off a wedding for the safety of friends and family. The next way that we can enable behavior at this time is by taking time to really understand all of the factors that can influence behavior. We actually just did a systematic literature review on this for hand-washing behavior and found that in outbreaks, we tend to focus on giving people lots of knowledge about disease and health, and we tend to rely on fear to motivate behavior. But we know that knowledge alone won't lead to behavior change. And as you can see from this diagram on the right, there are many different determinants of hygiene behavior, and considering these in a holistic way can lead to programs which are more acceptable and which are more effective. The evidence also shows that the greatest opportunity we have to change people's behavior is through the provision of conveniently located, desirable infrastructure and products. And this really helps to create an enabling environment for key hygiene behaviors. This is particularly important as a takeaway for people working in crisis-affected settings where hygiene infrastructure and products may be more limited. If this is the case in settings where you're working, then this really does need to be your first priority. Doing hygiene promotion or awareness in the absence of infrastructure availability is likely to be ineffective, and it really puts your organization at risk of being seen as irrelevant or offensive from the perspective of populations. Here you can see some nice examples of simple infrastructural improvements. On the left-hand side is an example from IOM in Ethiopia. They're looking at using really simple local resources to prevent and control transmission at this time. So they've painted some sticks and they've put these in the ground to mark out distancing measures. They've installed a simple hand washing facility next to water points because they recognize that pump handles could be a key source of contamination at this time. Below this is a hygiene kit distribution in Yemen, where physical distancing measures were clearly marked out with colored sand. In the middle are some foot-operated no-touch hand-washing facilities that are being rolled out by WaterAid Nepal and in other settings to reduce contamination. On the right are some other simple ways of making facilities more desirable. So here you can see an example from Uganda where they've added a mirror to a hand washing facility to make it more engaging and encourage people to spend longer time at the facility. We also see an example on the bottom right of making soap more available in settings where it's limited by using soapy water made from laundry powder. So one of the challenges that I often hear from humanitarians is that crisis-affected populations are hard to reach. And this is often true, but it's important that we reflect on what hard to reach means. It means that our job as humanitarians is harder, but not that these populations are impossible to reach. So it's really important that we take time from community to learn from communities around what their preferred delivery channels are at this time. And here are some examples of creative ways that we can engage populations. So on the left-hand side is a poster. We do see lots of posters being used at this time, but most are quite information heavy. They're not very creative. So typically, if you're going to use posters, you need to make them stand out and be eye-catching like this, or to change messages frequently. We also see examples here of cues and nudges in the physical environment that can enable behavior. So in the top image here, you see footprints leading from the toilet to the hand washing facility. And this enabled a substantial increase in hand washing behavior in Bangladesh. In the bottom image, you can see germs stuck on the back of a toilet door to remind people that this is a surface that they're coming in contact with and therefore trigger hand washing. And we also see some examples on the top here of using radio creatively through the form of radio dramas or discussion programs from Moderator in Rwanda. And lastly, the image on the bottom right is one of several fun experiments that have been created by the WashM project, and they've created several short videos in different languages that are being shared on social media. So this basically wraps up my section of this presentation. I wanted to kind of leave you with a few general principles for hygiene promotion during coronavirus response. And the first is that we obviously all need to plan for circumstances to change. And this means that your organization should consider how to change your programs should the situation get worse or improve. And you should align this with government plans, local epidemiological data, and WHO recommendations, of course. Secondly, if the situation isn't too bad where you're working at the moment, then use this window of opportunity to set up communication networks that allow you to continue to work with communities at a distance should the situation get worse. Thirdly, of course, coordinate and share with others. This includes sharing information we collect from communities and our programs, but it also, includes collaborating with a range of actors, including non-traditional actors like businesses, so that we can effectively meet needs at this time. Lastly, we need to make sure we remember at all times that for the populations we're working with in crisis-affected areas, this is just the latest in a series of challenges that they will have faced. So remember that, we need to put this within a broader context. We need to remember that economic needs sometimes trump health needs. And it's important that we link up our hygiene and wash programming with these other initiatives. And we can actually use the fact that people have been through so much in these settings to remind them of their resilience and that they will be able to cope with this current situation too, so long as they kind of pull together and we can leverage a sense of community spirit through our programming. So I'll leave it there and I'll hand back over to Les to introduce the next speaker.
Lauren, thank you so much. So our next speaker is Carolyn Maturi. She is a water engineer by training, and she's part of Oxfam's global humanitarian support personnel. She, at the moment, is based in Nairobi, but she does wash support for Oxfam's programs in Bangladesh, India, and where she's going to talk about today, the Eastern DRC. So Carolyn, thank you so much for joining us.
Thank you so much, Dr. Les, for that introduction. And similar to Cyan, I'm going to put my video off just to make sure that the bandwidth is great. And during the Q&A, I'll put back my video on. Okay, Cyan, next slide, please. So in DRC right now, the current caseload for COVID-19 is 1,102 cases. But one of the things I need to point out at this point is that most of the cases are concentrated in Kinshasa, which is to the east. And if you look at the map, I'm going to give lots of emphasis on where we've got an ongoing Ebola response, which is the North Kivu province, and it borders Uganda and Rwanda. So at the moment, as of yesterday, the confirmed COVID cases in the entire province are 8, and all those cases are actually in the cities, with 6 cases in Goma and 1 in Beni and Kasindi. Most of these cases, or rather all of them, are actually imported cases because of air travel between Goma and other parts, especially for cargo movements, and then we find people coming in one or two people. So the focus of my presentation is where we are doing Ebola response, like I said, in Butembo and Mangena, and there are no cases at the moment, no cluster of cases or community transmission whatsoever. Next slide, please. Next slide, please. Cyan. Okay.
Can you see
so
that?
yes. Sorry. So for the community perceptions, this is the feedback that we are getting from communities. At the moment, as I said, we are doing preparedness, and we are also making sure that we are trying to reach the communities, but we are also listening to them. So right now, the top key concern or feedback that we've received is, of course, confusion between Ebola and COVID. For those of you who know the signs and symptoms of Ebola and are conversant now with COVID-19, we've got two symptoms, which is fever and also fatigue, or this form of weakness, body general weakness, which are quite cross-cutting against the two. So really the community needs a bit of time to be able to understand what is the way to really differentiate between an Ebola case definition and COVID-19. Again, because of the issues that have been there on the media, showcasing high cases in Europe and the US, and of course, lots of deaths in countries like Spain and Italy, this is also building a perception that COVID is a disease for the rich and not the poor, like Ebola was. And also there's an aspect of a feeling that the humanitarian agencies and politicians are trying to come up with a way of remaining in business because Ebola cases are on the reduction. Okay, so and for people who've worked in DRC, for those of you who don't have the understanding, DRC has got a history of lots of issues, and this has got to do also with the fact that when Ebola started, the community really looked at it as something that the politicians from the east were introducing in this North Kivu province, which is very, very marginalized. So there's also that perception building up. Now that Ebola has been contained, we are trying to come up with something else to keep us in business. The other aspect is, of course, there is a concern about vaccine. This is also built from Ebola. At the beginning of the response in late August 2018 and at the start of 2019, we really focused for the vaccine to the frontline health workers, and we were not doing mass vaccination to the community. So that creates a perception that perhaps there is a vaccine for COVID-19, but we are withholding it from the community just like we did for Ebola. And the last one is built on cultural beliefs. So there are still people who believe that COVID-19 is a result of witchcraft. Next slide, please. So what exactly is Oxfam doing? Okay, so in terms of our approach as an organization, what we are trying to do is really for WASH disease or WASH in disease outbreaks, we are looking at the epidemiological data and try to look at the trends on how the situation is evolving, and then taking that into consideration based on the knowledge about the disease and the behavior. Okay, so we are trying to look at those two angles together. So the knowledge and behavior vis-a-vis the trends that are coming up from the epi data, and trying to adapt our response as we move along. So at the moment, because COVID-19, like I said, in the community, we still don't have cases. We are doing a lot of capacity building to address the knowledge aspect, make sure that our staff and community groups have a great understanding of what COVID-19 is, and especially in this place where we have to differentiate it from Ebola. Again, for the communities, we are doing regular dialogues with specific community groups so that we encourage, like Cyan was saying, we encourage the behaviors that are able to reduce the COVID-19 transmission. Again, because hand washing is one of the key behaviors that has been identified to be able to contain COVID-19 as well as Ebola, we are doing as much as we can to make sure that we install as many hand washing stations together with the community, trying to adapt and listen to them, and make sure also we increase the soap distribution. The other thing for us, Oxfam, that is very, very key, building on lessons from Ebola, is we are tracking our feedback from community in a systematic manner. So we do have a tool that we are using that is called the Community Perception Tracking Tool, and that is going very well, and I'll speak to it in a bit. In addition to this, of course, as Oxfam, we are not working in isolation. Next slide, please. We do have a coordination or task force mechanism in the areas that we are working in Butembo, Beni, and Mangina, and also in Goma. And so we are working alongside other agencies that are contributing to similar efforts. So specifically when it comes to behavior change and risk communication, which is very key for epidemics, there are other agencies that are focusing on increasing the access to information using culturally appropriate channels, especially the local radio stations. And for them to be able to do this effectively, they're trying as much as possible to work with local artists, religious leaders, people that have an understanding of the languages that are mostly used, which is French, Lingala, and Swahili, and also the journalists that are actually doing the broadcasts, making sure that we have an understanding of the local language and we are able to deliver the information to multiple people in the language that they prefer. Again, at the moment, there are discussions if we can move this to TV and be able to do interactive shows, because of course, as I said, COVID is really, really new. And so we are looking at whether we can, other partners are looking at being able to do this through local television shows. Next slide, please. So having said that, what exactly is going on well? Okay, what is going on well? Sorry, I still can't see the slide, Cyan. I don't know if it's my side or, okay. Before we go to what is going on well, what have we learned from Ebola? As I said, we have been responding to Ebola. We are still going on because the place is not yet Ebola free. WHO has not made that declaration. Previous slide, please. The previous slide, please, Cyan, sorry. The lessons that we would like to make, yes. So based on Ebola, we have been implementing, as I said earlier on, since August 2018 until now, we are still implementing. What are some of the things that we have learned that we can actually build on in terms of lessons from Ebola? So one of the things that we've learned is that really community-centered approach is key. So we really need to make sure we listen to our communities and adapt the response. Those of you who have access to literature, you do know that at the beginning of Ebola response, the community was very resistant and they would act out by banning some of the health facilities that we were running and also stoning the vehicles that were carrying the humanitarian aid workers. So really we have to listen to the community, and we are trying to do more of that and be able to do centered approach when we are doing everything that concerns the community. The other thing is, as I said, in DRC, we have many underlying risks, not just WASH risks, but we also have things like gender-based violence that we really need to make sure that we are analyzing and seeing how they impact our own epidemic or washing disease programming. The other thing that we learned as well in the process of implementing Ebola is that for behavior change, there has to be an integration of the hardware. Okay, so for example, if you're talking about hand washing facilities, you provide the facilities, you provide the water, but at the same time, you need to make sure that you consult the communities and listen to them. How would they like to contextualize that device, or how can we make it better? The other thing that was very key is often than not, we need to remember that for epidemics, it's not just about WASH. It is very heavy on the health aspect because this is a disease, but as WASH, we are contributing. And so one of the things we learned, if we have to change the health-seeking behavior, is we have to work more on the healthcare facilities. In a country like DRC, the healthcare facilities was very, very poor. And so the communities were not attracted to these healthcare facilities. They wanted to go to traditional healers and witch doctors, things like that. So we needed to do more on the WASH aspect to make the healthcare facilities look attractive. The other thing that we learned is women are the primary caregivers. And for that reason, we need to do more and engage them. And based on the risk analysis, there are many reasons why women always tend to be missed out. So looking at all these things that we have learned from and what we are trying to do more of to adapt into the context, what exactly has been working well? For us, especially in the area which was the hotspot for Ebola, which is the area I'm talking about, Butembo, Beni Mangina, we have now seen an increased trend of community trust. And this is because we already have a well-established community network through what is called the CSAs, and we also had established women groups and religious leaders. So for the CSAs, it's the committee at the local level of community, and it is built from different, comprising different people in the community in a way that everybody is represented. And one of the things is now Oxfam has used that established community network to be able to extend on the COVID-19. So unlike at the beginning of Ebola, where the community would not allow us access to their place to discuss about Ebola, right now through this established community network, we are talking to them, and they're able to really understand what we are saying and allow us even to discuss this issue. The other thing that is important to point out at this point is in our Ebola response, if you look at the picture that is shown there, this is an example of a spidergram that I used at a task force level meeting to be able to share the feedback from the community. So what we did is we used 3 CSA members to be able to give feedback on the different pillars of the response. Apologies to those who don't understand French, but those are basically all the pillars that are in an Ebola response. Things like EDS is safe barrier, PCA is infection prevention control. And so we would go to the community and tell them to give us feedback on each pillar, what has been done well and what they would like changed. And then using that feedback, I go to the coordination that is led by the Ministry of Health, of course supported by WHO, and then we are able to adapt our response as a whole. Lastly, because I can see time is not on my side, there are challenges, of course, in any program. Next slide, please. So the key challenges right now, I will focus on the first one, which is really, really important. Yes, we have been working in this community, but for hygiene promotion and really for behavior change, we need to have an enabling environment. Okay, so for the enabling environment, we need water and we also need hand washing devices. So still in North Kivu, there is a big problem with water. Water is very scarce, and also the hand washing devices are still not enough. Of course, as Oxfam, we are trying to be innovative, and we are looking at ways we can do hand washing devices that address this issue. If I'm a local woman and I only have water that is 5 liters, I don't think I'll be able to use it for hand washing behavior. Rather, I'll use it for drinking and also cooking. So we need to come up with hand washing devices that really conserve water, and then the communities also realize that the burden, especially for the women, is reduced. The other key challenges are really generic, and perhaps the one that crosses across the entire country is I'm not very sure at this point that we are transferring knowledge from what we have learned in the North Kivu area with those that are actually implementing the COVID response in Kinshasa. I still think there's a lot to do because the two contexts, of course, are very different, but the national staff that are in North Kivu are very different from the ones that are in Kinshasa. Thank you very much, Les. Over back to you.
Carolyn, thank you so much. That was wonderful. Let me remind everyone that if you have questions, please put them into the chat box and we will attempt to get to them at the end of the now third and final talk. Pardon me. Hani Taleb is a dentist by training, and he's the CEO of Relief Experts Association in Northwestern Syria. And to give us a radically different setting than we just heard, we would like Hani to tell us about their efforts to try to control COVID in Northwestern Syria. Hani?
Thank you, Les, and thanks to Sean and Caroline for the inspiring presentation, and good morning and good afternoon to everyone joining us today. Now, for those of us who don't know what's happening in Syria, Syria is a country that's been under war since 2011. It is now controlled and it is now divided and controlled by three main actors. I'm going to talk specifically about Northwest. The area has been targeted by military activities since 10 years now. It mainly relies on aid provided through Turkey. It has a population of 4 million. 1/3 of them are in acute need, and almost 2/3 are actually internally displaced. At the moment, this area doesn't have any confirmed cases of COVID-19, although the rest of Syria has 47 cases and 3 deaths so far. Next, please. Now, what we have done right from the beginning is trying to maintain a community feedback mechanism so that we can have a two-way communication. And we've done a couple of surveys involving community members and community leaders to actually see what different perceptions are there. So according to 10% of the population, COVID-19 is not a dangerous disease. And this goes to 20% of the leaders when we question them. The community also thinks that there are no cases at the moment in Northwest Syria, so there is no actual need to take precautions. Because the area has been under heavy military attacks and airstrikes and bombing for 10 years, people actually say that, you know, this is the first time we actually have clear skies. So COVID has been kind of a positive thing, maybe towards Northwest Syria, where military activities have actually been limited recently. So people actually say that this is the first time we have clear skies. So now you're asking us to stay at home. It's almost impossible. People also think that they have suffered death for 10 years now. They have suffered too much death. So why bother if few more die? People also think that because they haven't seen a drastic change or a scale up in health facilities and health response, they think that the international community and the authorities, the local authorities, do not really care. So why should they? Next, please. Now, because there is no central government in Northwest Syria, unlike other places in the world where you would rely on these governments to actually lead the response, we've established a task force comprising NGOs and other actors. Now, under this task force, we've established what we call the Corona Awareness Team. This is a team that has NGOs, civil actors, local health directorates, and others to actually coordinate and lead the awareness activities. Now, this team, with support from WHO and UNICEF, has been dispatching awareness teams, organizing public campaigns, utilizing the existing aid networks because there is no actual infrastructure for basic services. And so we rely on alternative networks through aid activities. And this also involves social media for communicating with people because there is no national TV or radio at the moment. The team has also been training aid workers, health and non-health workers, increasing access to water and soap, and also improving communication with religious leaders, community leaders, and de facto authorities. Next, please. Other actors have also been doing a number of activities, including disinfection of public facilities. There has been a change, a slow, but there is a change in how aid is being distributed so that we can actually avoid crowds and move into more safe ways for providing aid. Some actors have also been piloting distant learning. Others have also started doing recreational activities to educate children about the threat and how to protect themselves, but in a more child-friendly manner. And all of us have been actually enhancing the use of social media to communicate with people, knowing again that there is no actual infrastructure for doing that. And also in a way to plan ahead so that once God forbid, the disease is there, the outbreak is there, we have some alternative ways to maintain talking to people. Next, please. Now, certain things we've considered and put in mind while planning this response, and these are basically related to the current context, because we know that the health structure, the health infrastructure has been destroyed, even systematically destroyed during the past war. The plan contained a significant component for enhancing the hospital capacity and adding community-based isolation centers for when cases started to appear in the area. Because we also know that the community knowledge about the disease in general is low, so we put activities to enhance risk communication and community engagement throughout northwest Syria. Also because we know that the war has actually beaten the economy, and people really rely on daily living. So actually people cannot really stay at home or avoid crowds because they have to make a living on every single day. Otherwise they will not have food on the table. So it's almost impossible to tell people to stay at home, avoid markets, when they actually have to work every day. So there was a plan, it's in process, to actually scale up the response and scale up the aid, particularly in terms of food and hygiene, and actually wash services, so that people can have more access to basic services and try to avoid crowds and commit to social distancing. Now, because of all of this, we've been trying and testing some ideas to improve social distancing around markets, mosques, areas where we have normally significant crowds. Next, please. Yep. So to be honest, in terms of what we think that has been working well, because we, as I said, we have no cases at the moment, although there has been active testing, but we still don't have any case. We hope that it stays this way. But the main thing is the border limitation and the border restriction and even closure. Basically, northwest Syria has kind of isolated itself from the other territories in Syria, meaning that although the rest of Syria has cases, these cases were not allowed to enter northwest. And at the same time, significant control has been put on the border with Turkey. I mean, it's impossible to close it entirely because this is where the aid comes from. But there has been a lot of control on that. And this is probably the only reason we have at the moment for having 0 cases. Next, please. And last, I want to mention some of the challenges that we're facing. One of the largest challenges is the fragmentation of authorities. We don't have a single authority or a government controlling Northwest at the moment. It has a combination of armed groups and other local authorities, local councils, and so on. And so those authorities have been very different in reacting to the threat, and even when we actually try speaking to them. One of the other challenges also related to authorities is that some of the authorities have been actually listed as sanctioned groups, which makes talking to them almost impossible for NGOs and even the local health directorates, which has been chosen by the community to lead health responses. Even those are actually almost unable to talk to these authorities because these authorities have been listed as sanctioned groups. Now, the weak infrastructure, meaning that, well, we don't have law enforcement, basically, so that we can actually guide people into how to avoid crowds and commit to social distancing. We don't have a national TV or radio system so that we can actually talk to people and maintain regular communication and so on. The lack of proper housing, as I mentioned previously, 2/3 are actually displaced people from within northwest Syria, and at least 1.2 million live in tents. So imagine how difficult it is to actually ask people to stay at home and commit to social distancing when their home is actually a tent. Or actually also some others also live in unfinished buildings and so on. Lack of prevention or preventive material and financial resources has been brought up by the communities in a number of occasions where they want to commit to hygiene practices and disinfections and so on, but they do not really have the resources to do so. The fact that no cases of COVID-19 in the area has been announced yet is itself a challenge, because what we've seen is that at the beginning, people actually listened and started actually taking precautions. But moving on, people started saying that, you know, we've seen no cases, so we don't really think that this is a threat. And lastly, the lack of knowledge of the community. This is also a challenge that we're trying to overcome. These are all from my side, and back to you, Les.
Hani, if you could stay with us for just a moment. There are several people have asked about what do you do when your messaging and your social distancing guidelines come into sort of conflict with religious practices? And built into there, a couple of people asked, are you involving mosques and imams in your efforts? If you had any thoughts, I think people would like to hear them, please.
That's a very, very good point. We've realized right from the beginning that talking to religious leaders is a must. And we've seen some examples of religious leaders, imams, who have been actually against precautions because they thought that, you know, faith is enough to prevent the disease. But what we did is that we've engaged them. We actually invited them to some sessions, to some trainings. We actually explained to them more about the disease and how it actually can be a real threat. And we've seen some really good and successful examples with religious leaders actually joining us in announcing the precautions and convincing the community to commit to it.
Thank you so much. So there's now quite a few questions in the chat box. I'd like to toss one your way, Sarn. Several people have asked about the appropriateness of masks in certain settings, the appropriateness of masks in settings where COVID hasn't arrived yet. Is there a body of evidence or thinking about masks that you could share with us, or a place you could guide us? Thank you.
Sure, thanks very much for that question, Les, and it's definitely a question that we've been getting quite a lot. So maybe just before I answer that, I'll just quickly explain what I mean by we've been getting quite a lot. So together with others at the London School of Hygiene and Tropical Medicine, we're part of a kind of a collaboration of partners that set up the Hygiene Hub. And this is a kind of platform where people working in crises or in low and middle income settings can share their work. You can see here our sort of interactive map featuring programs in different locations, but we also have sort of resources where we pull together evidence around topics that are important for hygiene programming during coronavirus. And we also have a feature where you can reach out in real time and connect with a range of experts in global health and behavior change and WASH. So, you know, the website is here on the screen, and that's, if we don't get through all of the questions today, that's definitely a good resource where you can follow up on some of the questions that you might have. In relation to the mask question, you will find an article on the Hygiene Hub about this, pulling together and summarizing the evidence. Basically, you know, the mask question is particularly complex because our evidence is a little bit contradictory at the moment. We see globally very different national guidelines around masks, as I'm sure many of you are aware. And we know that they have some positive benefits. Well, firstly, there are different types of masks. We should, of course, be leaving primarily our N95 respirators and our surgical masks for healthcare workers and those who need them at this time, including those who may have symptoms or be caring for a person with symptoms. But if we are talking about sort of fabric or homemade masks, then they have both benefits and drawbacks. Masks alone are not enough to sort of prevent coronavirus, and they need to be accompanied by really good hygiene and close management. So, you know, at the moment, we are recommending that, for example, hygiene promoters who are regularly in communities and are interacting with people on a daily basis, that it would be useful in some settings for them to use these homemade masks, but that they should be replacing those regularly throughout the day and sort of storing them safely and making sure that if they come into contact with their mask, then they are also washing their hands with soap. So do have a look at those guidelines, because the message is a little bit nuanced on this point.
Thank you so much, Sarn. So Carolyn, there are several questions have arisen about how do we monitor and how do we sort of encourage, maybe even enforce our hand washing guidelines and understand hand washing compliance. Could you give people a little bit of sort of your insights on how to promote compliance and monitoring? And you're muted at the moment, please. Carolyn, you're muted.
Oh, sorry. Yeah. Sorry. Yes, I think one of the key things that many sector leads, and also we are seeing a lot of push also from governments that are asking for, is we talk a lot about community-centered wash and also in behavior change, but then how do we monitor, how do we measure? So one of the practical ways we have found out from our experience, especially in DRC, is it's very easy to measure community engagement or involvement in terms of satisfaction. And then when it comes also to behavior and practice, of course, for hand washing, one of the key things, although it's very time consuming, is structured observation. So if you're looking particularly just at hand washing as a behavior, you can do structured observation where you check when people are washing their hands, how much, the critical times that we had traditionally, or even just within a day or a period of time, what is happening, the hand washing facility. You can also observe the amount of water that is going into it. So especially for the practice itself, structured observation is very key, but most of the times the backlash we get is it is time consuming. So the other thing to really make sure that we measure in terms of communities, because they're the ones that are using all these recommendations that we are giving them, and the behavior change as well is happening within their setting, is you can go back to them and ask them in terms of satisfaction. We are trying to promote hand washing facilities that are user friendly so that we can encourage the behavior. So how about going back and asking the community, is this hand washing device actually user friendly? Because then that answers, it's a proxy indicator of telling us that yes, the hand washing facility is user friendly, they're using it, and that means there is an increase in the behavior change. So it's a combination of both. There are times we can do direct structured observation, or we can use proxy indicators to monitor the behavior change over time. Back to you, Dr. Les. Thanks.
Carolyn, we only have 5 minutes and we've got a lot of questions, but a couple people have asked, what does Oxfam think is the amount of water typically needed to promote proper hand washing? And is that sort of considered in the sphere standards? Does Oxfam
yes
rule of thumb?
Yes. So yes, one of the things I can do is perhaps I can provide also a link in the Oxfam hand washing device that we are actually promoting. We have tested it in multiple contexts all over the world, and one of the key advantages of that device is that it conserves water. So when you put water, we did testing in different pilot locations. What we realized is for the 20 liters that goes into the container, a family of about 5 people can actually use it for multiple washes in a day without refilling it. But remember, for Oxfam, there's also the aspect of the handy tap. So the tap we are promoting also conserves water. So I think the link would be easier. And then people, if they're interested, we can provide all the research that we have done. Our hand washing facility has got more than 25 out of the 30 researched attributes that make a hand washing facility friendly to people. So
Great.
I think there's more we can talk on that. I'll provide the link.
Thank you so much. So Hani, a couple people have asked, what do you do when social distancing isn't an option? When people are living in tents, for example. Do you have any thoughts or insights?
Well, actually, this is a real challenge that we're facing right now. And we've been trying to look for solutions, even asking the community itself on what would they think to be appropriate and effective in this case. Some of the ideas that we've been trying to test is that for local markets, for example, having one kind of product in the markets per day, that can be an idea that can actually reduce the number of people going to the market on that same day. More importantly, we've been really thinking that public wearing of face masks is really the practical solution that we might actually have at the moment, so that if we cannot really prevent people from going out and joining crowds because of obvious reasons, then at least provide them with masks that they can reuse, provide them with instructions on how to use it, and make sure that they're not looking at masks, getting this false sense of safety, so that we can actually give them a combination of instructions that, it's not enough to use the mask, you also have to use the other precautions. These are some of the ideas that we have at the moment.
Great, thank you. So Sarn, someone has asked, is spraying in public places, is spraying as a disinfectant technology an appropriate thing? And if so, could you give us any insights into where and what references you might know about?
Sure. Another great question, and one that we also have a resource on in the Hygiene Hub. So, spraying can be, disinfection generally can be important for those very frequently touch surfaces. So I mentioned earlier, the idea of disinfecting regularly the handles of water pumps, the kind of things that multiple people are going to interact with every day. What we tend to see that in mass public spraying initiatives, that the efficacy of these is a little bit questionable. We know that, in order to disinfect something well, you have to get a really good coverage with a product like chlorine, for example, and it needs to be left on a surface for some time. So mass public spraying often doesn't manage to achieve the kind of the detailed level of implementation necessary to actually make it an effective intervention. And so at this time, if you're prioritizing funding and resources, it's less likely than other initiatives to be an effective way of controlling coronavirus. But again, for more details on why that's the case, please do have a look at that article on the Hygiene Hub.
Thank you. So we are very close to out of time, but there's one last question that I think one of you probably would be well suited to answering. And that is, what have you been doing to protect your staff who are going out and giving messaging? Have you been doing remote training? Do they stand 4 meters away? Can you give us any insights into how you're protecting your staff as they do community outreach? And we'll wrap up after that.
Yeah, I can quickly answer this. Actually, yes, it is a priority because we're actually putting them at the front line. And if we don't really give them the proper precautions, then we're actually doing harm than actually causing good. So basically, one standard measure that all workers have actually been adhering to is wearing face masks and gloves in certain locations. This is a must. They have to do it. We've prioritized funding for this kind of activity right now. The second is actually we've switched into remote training in some areas where we can actually avoid having too many people at the same time. And at the same time, also, we've been putting some measures for any physical training so that we can have less people, have more precautions, standard measures to actually avoid transmission of the disease.
Thank you. And thank all three of you very much for just wonderful presentations. That was really enlightening. And I'd like to hand over to Paul Spiegel, who I believe has a couple thoughts before we leave. Paul?
Thanks. Thank you, Les, and thank you, Sean, Caroline, and Hanny. I actually will not be commenting on this. There's not much more to say, I think, than what everyone has said. It's been really interesting, and having the two different contexts, Caroline and Hanny, were really fantastic. So thank you. I'm just going to announce the next week's webinar, which is going to be on gender and gender-based violence. Obviously, a hugely important topic that perhaps has not received enough attention as it should be. And that's going to be followed the week after by nutrition, and then eventually nutrition and food security, and then eventually surveillance. So thank you all. Les, thank you for moderating. It was wonderful. And we look forward to seeing you all next week and hearing you all next week. Thanks, everyone.
Thanks to three great speakers.
Thank you.